Hello, everyone. Welcome to Exam 2 review for PNR 204. So thanks for taking the time to watch this. And hopefully I can go over all the information that are the really key concepts that you need to make sure you know for your Exam 2 that's coming up next week. So to start off with, we're going to go over some key concepts that you need to know for the exam to make sure that you're fully prepared. I would say, either make flashcards or however you study terms best, but I would definitely know the terms that are on this first slide here. So generally speaking, meningitis is inflammation of the membrane that covers the brain and the spinal cord. So it's most often caused by bacteria. It can be caused by viruses. It can also be a chemical exposure. So it is a general term that is inflammation of the membrane that covers the brain and the spinal cord. Whereas encephalitis is deeper, it's actual inflammation of the brain. So I would definitely be able to differentiate between both of those terms and to recognize that meningitis is treated with antibiotics. And then osteomyelitis is an infection that we talked about this term. It's an infection of the bone. It's actually pretty deep into the bone marrow. It's not uncommon that children that have osteomyelitis had some sort of an injury to their bone that preceded the development of the osteomyelitis. So it could even be a fracture or an injury where they fell and hurt themselves, but then there was bacteria that got in there and then ultimately traveled into the bone marrow. And there's a couple of different cancers that we talked about. We talked about osteosarcoma and Ewing sarcoma. Those are both cancers of the bone, so I would be familiar with both of those terms. And then Reye's syndrome is a acute non-inflammatory encephalopathy, so kind of cognitive dysfunction, and hepatopathy, so liver dysfunction. And it is preceded by giving aspirin to children that have viral febrile illness. So we definitely encourage parents not to give aspirin to children. And it's important to remember that aspirins are part of the salicylate family. And it has both neurological and GI presentations. And it is most common after they take aspirin when they have flu-like symptoms or they have a viral febrile illness. Another significant infection of childhood is sepsis. So sepsis is a systemic inflammatory response. It's usually in response to either a bacterial or a viral infection, but it can also be in response to a fungal infection. Patients with sepsis tend to have high fevers, high heart rate, low blood pressure. It's treated with fluid resuscitation and antibiotics or antivirals, depending on the cause. There is a term that was discussed in the chapter that's called conscious sedation. So conscious sedation is administration of drugs so that a child is sleepy, but not totally asleep. So they remain their protective reflexes like their gag reflex. So they're able to maintain a patent airway, and they're still able to respond to physical and verbal stimuli, but they're sedated so that they're sitting still for a procedure. So you might use conscious sedation for like a chest tube placement or for a lumbar puncture, some sort of a procedure where the child's going to feel pain because they're going to be poked with a needle. And it's really important that they sit still for the procedure. So nurses are frequently involved in conscious sedation. They administer the medications and they also monitor the vital signs. And then a clinical pathway is a interdisciplinary plan of care that progresses throughout the entire treatment plan of the client. So it's different than a nursing care plan because nursing care plans focus on the role of the nurse, the decision making specifically of the nurse and the plan of care from the nurse's perspective, whereas a clinical pathway is really an interdisciplinary plan of care. And speaking of clinical pathways, if you're working with hospitalized patients, then you really need to remember that discharge planning really begins on admission. So their clinical pathway should lead them to an appropriate discharge where all of their discharge criteria are being met. And when you're dealing with children in the hospital, you may sometimes deal with what's called an emancipated minor. So an emancipated minor is an individual, an adolescent who's under the age of 18, but has been given legal authority to consent for themselves. So if you have a a 16-year-old that comes in for a tonsillectomy and they've signed their own consent form, that might be legal. You need to find out if they're an emancipated minor before you ask or follow up and make sure that some other adult signs their consent. So next, we're going to go over a couple of different theorists that are important to know. These are the same theorists that we talked about for exam 1, but since now we're talking about children in the hospital and adaptations to providing care to hospitalized children, it's important to know these theorists so that you make sure that you're giving developmentally appropriate care. So Freud is the theorist that focused on the psychosexual development. And when you think about Freud, it's really important. I would say when you think about all the theorists, it's important to really think about a child in that age group and what behavior is normal for them. So the infant stage is the oral stage, and children in this infant stage, this oral stage, they really get pleasure from their mouth. So the oral stage is that stage where babies really like to suck on a pacifier. They're constantly putting their fingers in their mouth, or they're exploring the world through their mouth. And then the anal stage, which is age 2 to 3, this is the potty training stage. And in this stage, kids are really kind of obsessed with their bowel movements and pooping. Sometimes they get scared when they see the toilet flush and their poop goes away. So a lot of their thought processes are about their anus and their body. And then as they get a little bit older, they move into the phallic stage. This is going to be your preschool going up to when they start like first grade. And this is where children are really attached to their opposite gender parent. So boys are going to be attached to their mother and girls are going to be attached to their father. And as they kind of get over that, they move into the latency stage, which is, school age until the start of puberty. And in this thing, children, they really spend most of their time with their same-sex peers. So this is going to be children are playing on the same sports teams, where it's girls on the girls soccer team and boys on the boys soccer team, and they're not really playing mixed co-ed sports. They're just kind of hanging out with their own peer group, which is usually going to be their own gender. And once they start to get towards puberty, that's when they start interacting more with the opposite gender. So, in terms of Freud, we've talked about most of these points on this slide, but Freud's stage of orality, in which the infant explores the world with their mouth. This is going to be tasting things, putting their fingers in their mouth. This is kind of how the babies get to know their environment. Anility corresponds with the toddler stage, and learning to give and take and exercising power of saying no. So anility is kind of the potty training stage, and also that Erikson stage of autonomy versus shame and doubt, where they're really wanting to become autonomous and they say no a lot. The next stage, the phallic stage, is that preschool age child when they're aware of gender and they are very, very attracted to their opposite gendered parent. And then latency stage is Freud's developmental stage when school age children are focused on same-sex peer relationships. And then the last stage, the genital stage, is when they start being sexually attracted. So Piaget is also a theorist that you need to remember. And I feel like there's quite a bit of overlap between Piaget and Erikson, but you still need to know that, sensory motor is Piaget and oral is Erikson. So sensory motor is Piaget's first stage of development, and it's age 0 to 2. And this is when their infants are really exploring the world with their motor responses. And they're still also putting things in their mouth and exploring their environment by touch and feel. One of the main things that's developed cognitively in this stage is the idea of object permanence. And object permanence is if they remember that you've taken an object away from them. So if they have their favorite rattle and then you put the rattle behind your back, they will remember that the rattle was just there, and they'll look for the rattle. So after the sensory motor, you move into the pre-operational, which is the age from like toddlerhood until the start of the school age years, so 2 to 7. They're a lot more talkative in this stage. This is like a lot of language development. They're still pretty imaginative. They could have an imaginary friend during this time frame, but they're not abstract at all. They're imaginative, but not abstract. And then going into the school age years, that's the concrete operational. This is where they really start getting better at math and they start understanding some more complex math ideas, but they're still very concrete and they follow rules and they're very logical. And then the formal operations is, getting into adolescent years, so 11 years plus. And this is where they start to develop abstract thinking. So this slide just kind of goes over the information that was on the previous slide. And we can just go ahead and give some brief examples. So sensory motor, this is exploring the world by touch and movement and learning by their senses. Whereas pre-operational, that 2 to 7-year-old, this is the imaginary friend stage, the really talkative, talkative preschool age child that's really got a lot of language developing happening, but it's still not very logical or concrete. And it has a lot of fantasies and imaginary thoughts. And then the concrete operations is the school age. And this is when they're starting to understand cause and effect. They're getting a lot better at math. And the formal operations is teenage years. And that's when they start to develop abstract thinking. So Erickson goes from infancy through 65 plus. We only talked about up through the teenage years. So the basic premise of Erickson is that in each stage of development, there's a conflict that must be successfully completed in order to have a healthy personality development. So trust versus mistrust is the infancy stage. And if an infant is able to trust that he's going to get fed and his diaper is going to be changed, he's going to be comfortable and warm and have everything that he needs, then he develops a sense of trust. And then, he'll continue to grow older. Toddler autonomy versus shame and doubt. This is the stage where kids really want to be able to be autonomous. They're very egocentric. They focus a lot on themselves. They want to be able to do things for themselves. Initiative versus guilt, which is the 3 to 5-year-old range. This is, the preschool years where you want them to try new things so that they develop a sense of initiative, but you also want them to try things that are age appropriate so that they learn that they can accomplish things. So don't expect a 3-year-old to always stay on the lines when he colors. You can just be proud and praise him for coloring, but not like make some sort of unrealistic expectations about how neat or pretty the picture is going to be. So you want to, get the kid involved in activities so they develop that sense of initiative, but you don't want to criticize them when they're, doing something that's not perfect because you don't want them to feel guilty about anything. And then they move into the school age years, which is going to be the 5 to 13-year-old or 5 to 12. So industry versus inferiority, this is where you want kids involved in a multiple of different experiences so that they feel like they're competent and they develop a self-esteem, but they should have some say in what they want to do. If you love sports and you have a kid that loves art, it's okay for your kid to do art. They can kind of be drawn to specific activities that they're naturally good at and feel a sense of competency by completing those skills. And then the teenage years is going to be identity versus confusion. It says 13 to 21 here, but kids are kind of going into puberty younger. So if you're kind of entering the teenage years from a hormonal perspective, et cetera, this could be maybe 12 years old. But this is the age where they're really starting to identify their sense of self and what they want to do in life. So this is going to be a little bit of a rehashing of, the slide that we just talked about. But the general idea with Erickson is that, like I said, there's a conflict at each stage of development, and then successful completion of that conflict leads to a healthy personality, and it starts with the development of trust as infancies. The toddler years, which is the autonomy versus shame and doubt, you want them to be able to do things like feed themselves, dress themselves, learn to express their needs, become potty trained, develop that sense of autonomy. And the initiative versus guilt, you want them to, start to feel that they are able to do things and not to criticize them too much. You don't want them to feel guilty. School age, industry versus inferiority. This is, where they really start getting involved in team sports or group activities, and they respond really well to getting recognition for their accomplishments, but they should also have some say in what they want their activities to be. They should be able to really self-select things that they're good at. And then the last stage in terms of the pediatric class, the teenage years, identity versus role confusion, where they're really focused on development of their self-definition and their self-esteem. So Maslow never goes away. Maslow's hierarchy of needs always just focusing on, physiological needs like having a place to sleep, having food, having shelter, takes precedence over even physical needs, like staying dry. And then that takes precedence over love and emotional belonging. So just always thinking about making sure the base of the pyramid is met in terms of the patient needs before you start really thinking about the esteem needs. And it kind of goes from physiological up to self-esteem. So Kohlberg is the moral theorist that talks a lot about why people at different ages choose to follow rules. So in infancy, this is, they don't really have a moral compass, right? They don't really have the ability to have a thought process about doing a certain activity. So it's, there's no difference between doing right and wrong. And they're not avoiding punishment because they're just too young. And then as they kind of move from, from infancy to like toddler years, that's when they really start to think about, well, I'm not going to do something because I don't want to be punished. That is something that really focuses highly on their brain. And that idea of like, I don't want to get punished, it never necessarily goes away. But they do adapt over time, where then they also start to think about, well, am I going to get rewarded for this? Am I going to be perceived as being a good girl or a good boy? And and that takes precedence. But the idea of like, I don't want to get punished, it never actually goes away. And then as they move through their school age years, they become really rule oriented, where they follow the rules because they think it's important to follow the rules. And then once they get to their teenage years, that's when they can start to have a little bit more of like abstract thinking, or to be able to develop a nice sense of something should be done because if it's right or wrong. They're not really focused on following the rules for the sake of following the rules. So those are, a quick summary of the different theorists that are the most important ones that we talked about during class. And then we're going to move on and talk about some specific physiological problems that could land a kid in the hospital. So we're going to talk about fractures, sprains, and strains. There are several different types of fractures, and the next slide has a picture of all of them. But this slide that we're looking at right now kind of goes over the main ones that you really need to know. So a green stick fracture is an incomplete fracture, so it doesn't go all the way through the bone. Whereas a compound fracture is a complete fracture of the bone and the skin is broken. So they're at an increased risk of infection because it penetrates the skin. So a simple fracture, kind of as the phrase suggests, the bone is broken, but the skin is intact. So this is a lower risk of infection than a compound fracture. And an oblique fracture is a break at an angle. And a spiral fracture, this is the one that is associated with child abuse, because you have to like twist the bone in two different ways in order to have a spiral fracture. So unfortunately, when we're talking about injuries to kids, we always have to be concerned about the possibility of child abuse. So there's several different things that can trigger child abuse. Premature infants, children with chronic medical problems, children that have behavioral problems are all at greater risk of being abused. It's also true that parents who were abused themselves are at greater risk for abusing their own children, or if there's substance abuse, poverty, financial stress, or if low self-esteem or the parent feels worthless or incompetent, all of those things can lead to a higher incidence of child abuse. So when we're talking about injuries to children, there's obviously the fracture, and then there are soft tissue injuries. So sprains, strains, and contusions are the three different categories of soft tissue injuries. So a sprain is when the ligament is torn or stretched away from the bone. And so a ligament is the connective tissue that connects bones to bones. A strain is a microscopic tear in the tendon, and the tendon connects muscle to bone. And then a contusion is the rupture of subcutaneous capillaries or blood vessels that cause the bruising and discoloration. So all three of these soft tissue injuries, the primary treatment is the RICE acronym, which is rest, ice, compression, and elevation. This next slide here goes over, it gives you a pictorial image of the different types of fractures. In addition to fractures, there are other things that can go wrong with bones. Uh, Something that you see frequently in teenage girls is something called scoliosis. So scoliosis is more common in girls than in boys, and it's that S-shaped curve of the spine. It can also cause uneven shoulders and uneven hips. In addition to that, there are two types of bone cancers in kids. There's Ewing sarcoma and osteosarcoma, and both of those are malignant bone cancers. And there is a condition called leg cap perthes, which is disruption of the blood flow to the head of the femur. So it can cause a degenerative disease of the femur head. It causes a painless limp. It happens spontaneously, and it almost always goes away spontaneously. But these, if you have leg cap perthes as a child, you could end up with joint disease in adult and long-term need a hip replacement surgery, but that is unusual. Most of the time, leg cap perthes is a self-resolving illness that goes away on its own without any treatment. And then juvenile idiopathic arthritis is an autoimmune disorder of children. It's, involves inflammation of the joints and connective tissue. And if it is associated with a high fever, then it's called systemic or acute febrile juvenile idiopathic arthritis. There are a couple of different muscular dystrophies. So it's a childhood muscular dystrophy is a childhood disorder that is a progressive muscle degeneration. The most common is Duchenne's. There's also another one called Becker's. These kids are typically diagnosed around the time you would really start to expect them to be walking and running. So 3 to 6 years. They tend to fall down a lot and be clumsy. It is a progressive disease with no cure, and most people die in their late 20s, early 30s of cardiac or respiratory problems. So this is a lot of supportive care from the nursing perspective, making sure they have the mobility devices that they need and the cardiac respiratory support that they need. And then another sort of musculoskeletal problem that children could have is something called torticollis, which is limited neck motion due to shortening of the SCM muscle. So you might see a kid that can't move their head from up to midline or something like that, or kind of stuck their head to the side, and that is called torticollis. So if children do have a fracture, they might end up in the hospital in traction. So there's skin traction, and then there's also skeletal traction. So skin traction is when you apply something to the skin, like a bandage or a gauze or something, and then that is what's hooked up to the traction. Whereas pin traction is actually putting a metal pin into the bone. So the general purpose of traction is to realign a body part, and it can realign bone fractures, or it can also help with knee injuries, getting the leg back into alignment after a knee injury. So in the kids over 30 pounds, we do talk about Buck's traction, and it's primarily used to treat knee injuries. And it is a type of skin traction, so you don't put any pins into the bone with Buck's traction. And then the younger kids, I know we talked about in class, there's one called Bryant's traction. That's for a femur fraction where the legs get pulled up into the air. The legs and buttocks get pulled up into the air. So there's a couple different types of traction in children. But regardless of the limb that's placed into traction or what the purpose of the traction is, there are some basic principles that you need to think about. So it immobilizes an extremity or a fractured bone, and you do it to eliminate muscle spasms and to relieve pressure on nerves. and it can also prevent or reduce skeletal deformities. And there are certain things that you do as a nurse. You think about neurovascular checks is the main thing that you think about in terms of having a patient that's in traction. So you need to make sure they have, they can feel the extremity. They should be able to feel it, but it shouldn't be too painful. They should have a normal pulse, normal color. They should not have any numbness, and they shouldn't have any lack of mobility. So if you have a leg in traction, they should still be able to move their toes. People who are in traction are not getting up and moving around. So they're never in semi-flowers or high fowlers. The maximum elevation of the bed is 20 degrees. They can't get up and go to the bathroom. They're immobilized in bed. The weight should always be free flowing, so they should never be on the floor. And you need to make sure that the traction setup is correct and that you're doing frequent neurovascular checks. In addition to leg traction, you can also do cervical traction, and the traction that's used for cervical traction is called Crutchfield. So cerebral palsy is a group of disorders that affect movement and muscle tone and posture of children. So this is something that they're born with, but they're not necessarily diagnosed as soon as they're born. It's associated with anoxic brain injury, so not getting enough oxygen during birth, or something happening in utero during the pregnancy that caused them not to get enough oxygen to their brain and neurological system. So sometimes they can be diagnosed later, like preschool age years, or sometimes they're diagnosed right at birth. They have abnormal reflexes. They tend to be spastic and rigid with bad posture. They have involuntary movements, and they have a hard time walking. And often they have a combination of all of those characteristics. There are some key terms that you need to know about CP. So they have, not infrequently, they have this athaltosis, which is involuntary purposeless movements. So it would be something like this with their hands, and they're not able to move their hands back into a normal position, and it just happens. So they can't feed themselves, etc., because they don't really have the ability to control their hands. And then spasticity is tension in certain muscle groups. So they tend to be, most kids that have CP have some element of spasticity. Spastic CP is the most common form of CP. So they kind of are rigid and taut. And then apisthontosis is this involuntary arching of the back. So this is, if you have these picture here on the bottom, is these kids that are born at these, this would be an example of a patient that was diagnosed at infancy, where they have this arching of their back that's caused by involuntary muscle contractions. So these are the key terms associated. I would for sure remember that this involuntary movement of the hand is this athaltosis, and most kids that have CP have spastic CP. 70 to 80% of kids that have CP have spastic CP. So when we're talking about injuries in kids, we need to be talking about pain management. So there's some people believe that you don't really use opioids in kids, etc. You really do. If pain is severe, the best medication is an opioid. You want to make sure that you're adequately treating pain and not assuming that kids can't feel pain, or they feel pain less than adults, or they don't need strong pain medication. So, and if you have a kid that's had like a fracture or some sort of injury, and you expect them to have pain for a logical reason, the best way to kind of make sure that pain doesn't get out of control is to do around the clock scheduled pain medication. Something like Tylenol is a great medication. So if it's scheduled every 4 hours, in that acute phase when they're highest risk for being in pain, you want to give it every 4 hours, even if you don't think they're in pain, because that kind of prevents the pain from getting out of control and you needing to give a higher dose or something stronger like an opioid. And then lidocaine can be given topically. Sometimes you can put a topical lidocaine patch on a hand or something like that when you're going to place an IV. And then, there's a couple of reversal agents that you should know just generally in nursing. So Narcan is a reversal agent for opioids, and flumazenil is the reversal agent for benzodiazepines. And then when you're dealing with kids also, it's important to know which pain scale is the right pain scale for your patient. So um, like the FACES scale can be used in kids that are over the age of 3. Before they're 3, they're not really coordinated enough to pick the face that represents their pain. There's another common pediatric pain scale called the FLAC scale, which is faces, legs, activity, crying, consolability. And the nurse can kind of look at the kid and make those determinations, and that can be used in younger kids. So when you're dealing with hospitalized children, I mentioned this before, discharge planning really begins at hospitalization. And you need to remember that separation anxiety um, is real for kids, especially when they're in the hospital, because they're not used to being separated from their mom and dad all day, and parents have to work and they need to leave. So it's not unusual for them to have separation anxiety. And there's the 3 stages: the protest, despair, and denial. And kids can go through all 3 of these in one hospitalization, where first they're in a state of protest where they're screaming out, crying for their parents all the time. Then they're in a state of despair where they're just sad and they don't want to interact with anyone. And then they can go into this denial or detachment stage where, they're going to play with their toys and not pay attention to the parents when they're there. So this, it can be associated with specific age ranges, with an older kid more likely to experience denial than a younger kid. But you can go through all 3. Like a 3-year-old can go through protest, despair, and denial in a single hospitalization, just as the separation from their parent continues. So when you're, trying to support a kid through the hospitalization, you want to make it as secure environment as possible. There's something called transitional objects, which would be like a blanket or a favorite toy from home that helps them feel more secure. You also want to try to reestablish their home routine as much as possible, involve the parents as much as possible, and kind of really get on a plan of family-centered care. Um, when you're talking about children that are coming into the hospital, it's not all that unusual that you will have a head injury patient, or a kid that fell playing sports or fell off a bike or whatever that had a head injury. So, one of the most important things that you do when you're monitoring kids that have head injuries is monitoring their level of consciousness. And there are certain things that can alter level of consciousness. One of them being a low blood pressure, also having a low blood sugar level, being dehydrated. Paying really close attention to level of consciousness is very important, because very subtle changes in their level of alertness or their level of consciousness can be an indication that you need to evaluate further and see what else is going on. So this section of the pediatric course also talked about sensory problems, so both the eye and the ear. If there is inflammation of the mucous membrane that lines the eye, that is called conjunctivitis. It's almost always infectious. It's a very common thing to go around daycares. It's highly contagious. When you teach parents to clean the eye, that when a child has conjunctivitis, you start in the inner corner and then you wipe out, and you make sure that you throw away that cotton ball. It's almost always treated with a antibiotic ointment or drops, and you need to make sure that parents know to finish the antibiotic course. So other sort of eye terms that you need to know: hyperopia is farsightedness, and myopia is nearsightedness. Um, there's a couple of different conditions that can be treated with eye patches. One is the amblyopia, and the other one is strabismus. So amblyopia is a lazy eye. That's when they have different visual acuity in both eyes. So like the right eye will be 20/20 and the left eye will be 2300. So when they have a lazy eye or amblyopia, you put a patch on the good eye to force the brain to use the bad eye. Another condition that you might see in childhood is strabismus, and that's where one of the eyes crosses. They don't have the ability to focus both eyes on one object. So one of the eyes is midline. This is more of a nerve problem and not so much a visual acuity problem. But it is also treated with an eye patch where you put the patch on the good eye to strengthen the muscle of the bad eye. And strabismus can ultimately be treated with surgery if the eye patch doesn't work. So nystagmus is jerky movements of the eyeball. So nystagmus is never normal. It's never normal for your patient to have nystagmus. Sometimes you'll see this when a patient is having a seizure, but it's important to know what that rapid eye movement is and to know that it's never normal. And then papilledema is edema of the optic nerve. So this is something that you can assess for by looking in the eye, by looking into the pupil with an otoscope. So in terms of the ear, all children that are born in hospitals in the United States get a hearing test at birth, but just because that's true doesn't mean everything is, caught. And there is something called congenital hearing loss. So this is going to be hearing loss that the newborn is born with. This can be hereditary based on a genetic predisposition, or it can be from an infection during the pregnancy. But regardless of what the cause, if the baby has the hearing loss from birth, that is congenital. And then conductive hearing loss is something is in the ear that's preventing sound from entering the middle ear. So this could be like even a buildup of earwax. So conductive is like the sound waves cannot be conducted into the middle ear. And sensorineural is when there's a problem neurologically or with the cilia hairs along the cochlea. So acoustic nerve 8 is the cranial nerve 8. If there's damage to acoustic nerve 8, then that's sensorineural, or if there's a problem with the cochlea or the hairs along the cochlea. If you're dealing with a child that has hearing impairment, you want to make sure that you're making eye contact with them, that you're speaking in complete sentences, that they're able to see you talk, and don't exaggerate or make a lot of weird mouth movements because that can make it harder for them to read your lips. And there's two different types of ear infections. There's the otitis externa, so that's an infection of the ear canal. And then the one that we talk about more often is otitis media, which is infection behind the tympanic membrane in the middle ear. And otitis media is most often treated with antibiotics. And it's really important as a nurse that you teach parents to finish the full course of their antibiotics because they can develop bacterial resistance and be more likely to have recurrent ear infections if the parents don't give the full course of the antibiotics. So the last topic that we're going to touch on here before we wrap up is seizures. So a seizure is any sort of abnormal and uncontrolled electrical activity of the brain cells. And it can be that they have epilepsy, which is a seizure disorder, or there are things that can predispose someone to have a seizure, like high temperature, hypoglycemia, medication reaction, etc. So not all seizures are alike, and not all seizures are associated with epilepsy. So a grand mal seizure is the generalized tonic-clonic. This is like the really big seizure where kids are on the floor, they're moving their hands, arms, legs. It's a full body seizure, and it's a jerking motion. This is possible for them to have irregular breathing. They might need to be intubated to control their airway, and they can have loss of bowel and bladder control. So a petit mal is an absent seizure. So this is a seizure that's sometimes a little bit harder to recognize. This would be like you're talking to the child and they just wander off and don't answer you. So you're having a conversation, they don't answer the question, and they just kind of stare into space for an extended period of time, and then they come back and they're back and they're able to communicate with you again. So that can actually be a petit mal or an absent seizure. A Jacksonian seizure is just another word for a simple seizure. So this is going to be one part of the body. So it's like an arm or a leg. It's unilateral seizure. And a myoclonic spasm is a seizure on awakening. So you kind of jerk and collapse right as you're waking up, and they're very brief, and they last about usually just a few seconds. So status epilepticus is a prolonged seizure that lasts more than 30 minutes, and post-ictal is a period of being sleepy and not as interactive after you're coming out of a seizure, as you're coming out of a seizure. So like I said, not all seizures are epilepsy. Not all seizures are a seizure disorder. So infection, fever, drugs, and hypoglycemia can cause seizures, and so can having epilepsy. Um, so we always want to make sure that we're making our patients as safe as possible. So in the hospital, you're going to make sure the side rails are always up, that there aren't any sharp or hard objects around the bed. Kids in the hospital always have to have their ID band on, but kids with seizures should have a medical ID bracelet. So if anything happens, whoever finds them having a seizure knows that they have a seizure and knows what to do. And then obviously, like if a kid's swimming and they have a seizure, that's a higher risk than a kid that will never seize and is swimming. So making sure that you're really monitoring kids closely that have seizure disorders when they're doing certain activities. And frequently in pediatrics, we really need to make sure that parents understand the importance of medication compliance. So the first line of treatment for seizure disorder is what's called anti-epileptic drugs, or AEDs, and it's really important that they get given on time at the correct dose so the patient means the therapeutic blood level of their medication to prevent them from having seizures. So the last thing that we're going to touch on is making sure that you know how to do your medication calculations. It's approximately the same number of questions on this test. 100% yes, you need to know how to do from weight, from pounds to kilograms, proper dosing based on the prescribed amount and the available amount. So for example, you have available 250 milligrams per 5 mLs and your patient's dose is 500 milligrams. You have to be able to figure out how many milliliters they need. So if you have any questions, I tell students all the time, if you can't do your math, you're just leaving points on the table. It's going to be 8, if not 10 points off your test if you don't know how to do your dosage calculation. So please, please, please make an appointment with me, or if you're one of Professor P's students, make an appointment with Professor P if you have any questions about the dosage calculations. So that wraps up the exam 2 review. If you have any questions, please send me an email. Good luck, everyone.